Welcome to Psych Talk. I am your host, Jessica Lee, a licensed clinical psychologist. It is my mission to motivate, inspire, and educate you on everything psychology, mental health, and self-growth. Although topics discussed on this podcast are similar to therapy, Psych Talk is not a replacement for therapy and is for educational and entertainment purposes only. Whether you are a mental health professional or student in the social science field, are interested in psychology and mindset shifts, or are just interested in gaining skills and knowledge to grow into the best version of yourself, this podcast is for you. My hope is to provide you with knowledge and skills that you can implement in your daily life that add up to make a big impact. Let's dive into today's episode. Hey everyone, welcome back to Psych Talk, and thank you so much for joining me for today's episode. As many of you know, I work in a children's hospital as a pediatric psychologist. And one of my specialties is pediatric chronic illness, specifically the intersection between chronic illness and mental health. And I did an episode back in 2020, it was episode 29, on chronic illness and mental health, but I haven't touched on it on the podcast since. So back in December of 2024, I did a grand rounds presentation at the hospital I work at on pediatric chronic illness and mental health. And I wavered back and forth on if this was something that I should also talk about on the podcast. And to be transparent, part of that was because I was unsure how interested people would be in the topic. However, on February 13th, 2025, President Donald Trump signed an executive order entitled Establishing the President's Make America Healthy Again Commission. I bring this up not to make this episode political, but to highlight the fact that chronic illness has been a topic of conversation in the current administration as well as the media. So I'm not going to read the executive order. You can go read it yourself if you haven't already. However, there is a focus in the executive order on chronic illness in children. Thus, since pediatric chronic illness is something I work with daily, I wanted to do an episode on it. But also, since this is a mental health podcast, I'm going to be focusing on the connection between pediatric chronic illness and mental health. So first and foremost, what is chronic illness? A chronic illness is any condition that persists for 1 year or more and requires ongoing medical attention or limits activities of daily living. And so when it comes to children, there are slightly different definitions of chronic illness. So for example, one definition is a health problem that lasts 3 months or more, affects a child's normal activities, and requires frequent hospitalizations, home health care, and or extensive medical care. Another definition is any physical, emotional, or mental condition that prevents a child from attending school regularly, doing regular schoolwork, or doing usual childhood activities, or that require frequent attention to the treatment from a doctor or other health professional, regular use of medication, or use of special equipment. So when we look at prevalence of pediatric chronic illness, rates of chronic medical conditions in youth are increasing. And this is theorized to be the result of advances in pediatric medicine, which have increased survival rates of conditions that were once fatal in childhood. So a good example of this is cystic fibrosis. And I can even look over the past 7 years that I have worked in a children's hospital and see the changes and advancements in medicine specifically for cystic fibrosis. So when I first started at the hospital back in 2018, I saw a lot of children and teens with cystic fibrosis. They were frequently hospitalized. They were always trying new medications, things like that. And my first patient ever actually passed away from cystic fibrosis. Now, I still see children and teens with cystic fibrosis, but it is very rare. It might be a couple a year rather than a couple a week. And that is because there have been so many advances in cystic fibrosis treatment that these individuals are not only living longer, they're living healthier and are able to stay out of the hospital. So yes, although we may see more children with chronic illness, that is at least in part due to the fact that children with chronic illness are living longer. So if they're living longer with the chronic illness, obviously there's going to be more of them. So prevalence rates of chronic illness vary depending on where you look. However, according to the National Survey of Children's Health, 19% of children ages 0 to 17 in the United States have one current life or lifelong health condition. An additional 18.7% of children have two or more current or lifelong health conditions. Youth from communities of color are 1.5 to 2 times more likely to be diagnosed with a chronic medical condition and often have poorer health outcomes. So, why is this? Implicit racial and ethnic biases among healthcare professionals, in addition to social determinants of health, such as food insecurity, inadequate insurance coverage, and inadequate access to medical care, are factors related to racial and ethnic health disparities when it comes to pediatric chronic illness. So, next, I'm going to talk about some common childhood chronic illnesses. Obesity is the most common chronic health condition in childhood. And I do want to make note, as someone who works with eating disorders, I do have pretty strong feelings about the term obesity or obese and what constitutes as such. But for the purpose of this episode and to be true to the research, I will be referring to obesity throughout the episode, as it is a chronic illness. That is how it's recognized by major medical associations such as the American Medical Association and World Health Association. So we're going to be talking about obesity in this episode. So approximately 1/3 of children and adolescents are overweight or obese, with higher rates observed among ethnic minority, Black, and Hispanic youth. ADHD impacts approximately 7 million children ages 3 to 17 in the United States, which is 11.4% of children. Asthma affects approximately 6.5% of youth under the age of 18. 352,000 children and adolescents younger than 20 years have diagnosed diabetes in 2021, which includes 304,000 children with type 1 diabetes. Approximately 456,000 U.S. children 17 and younger have active epilepsy, which is approximately 0.6% of children in the United States. Obviously, these are not the only chronic illnesses we see in childhood. However, they are some of the more frequent or commonly seen ones. So, what causes chronic illness? And this is a big thing, going back to what I said earlier about this being politicized in the MAHA movement, is what causes chronic illness. The good news is we do have a lot of information on the causes of various chronic illnesses. So, pediatric chronic illnesses arise from genetic or environmental factors, or a combination of both. So, certain chronic illnesses can be inherited, such as cystic fibrosis or sickle cell disease. Prenatal exposure to alcohol, tobacco, or other substances can increase a child's risk for certain chronic illnesses, such as ADHD. Air pollution can trigger chronic illnesses such as asthma, certain cancers, and cardiovascular disease. Smoking or exposure to smoke, as we are talking about children here, can increase the risk for a variety of chronic illnesses, including but not limited to cancer, lung disease, heart disease, and diabetes. Poor nutrition and physical inactivity are risk factors for chronic illnesses such as obesity, type 2 diabetes, heart disease, and depression. Infection or illness of some sort can also lead to chronic illness. And so, as you can see, there are a variety of factors that play a role in the development and maintenance of pediatric as well as other chronic illnesses. So, getting to pediatric chronic illness and mental health. A substantial amount of research over the past 30 years has demonstrated that children with chronic health conditions are at increased risk for mental health problems, including depression, anxiety, behavioral disorders, and suicide. A 2019 study of 48,572 youth found that youth with chronic physical conditions had increased mental health risk across all conditions, with a 51% greater risk for anxiety, 70% greater risk for mood disorder, and 54% greater risk for behavioral disorders. However, only about half of children with a mental health disorder receive treatment, with rates among youth with chronic illness being even less. So, stigma surrounding mental health treatment is one big barrier to getting treatment. There are also structural barriers such as finances, inconvenience, distance, long wait lists, and insurance barriers. An example might be providers not taking a certain type of insurance, not having insurance as another, as well as insufficient infrastructure for mental health services for children and adolescents in the United States. Integrating mental health services into medical settings is an important strategy for addressing the barriers to receiving mental health services, particularly for youth with chronic conditions. So, for example, integrating a mental health practitioner into primary care settings, patient-centered medical homes, hospitals, etc. Results of various studies examining integrative models show improvements in behavioral problems, depression, anxiety, as well as a reduction in stigma. It also helps with cost offset, including reduced hospitalization as well as reduced medical costs. So now that we touched on general mental health comorbidities and barriers to mental health care, I want to touch on some specific pediatric chronic illnesses and their mental health comorbidities. So starting off with obesity, because like I said, that is the most common pediatric chronic illness. Youth with obesity have increased rates of internalizing and externalizing disorders, problems related to body image, reduced quality of life, low self-esteem, social isolation, and discrimination. One study found that 39.8% of treatment-seeking children who were overweight or obese suffered from depression and or anxiety symptoms. In a meta-analysis, 21.7% of overweight or obese children were diagnosed with depression and 39.8% with anxiety, which was significantly higher than the 18% for depression and 14% for anxiety in non-overweight or obese children. Additionally, overweight adolescents have 4.91 times higher risk of eating disorders than non-overweight adolescents, and 36.5% of obese children aged 10 to 16 years experience binge eating episodes. Next, let's talk about diabetes. Individuals with diabetes are at greater risk for depression, anxiety, psychological distress, and eating disorders compared to their healthy peers. With regard to depressive and anxious symptoms, a meta-analysis found that 30.4% prevalence of depressive symptoms and a 32% prevalence of anxiety symptoms in youth with type 1 diabetes. Estimates suggest that up to 33% of adolescents with diabetes experience diabetes distress, which is specific negative emotions directly related to living with diabetes. Further, 21.2% of youth with type 1 diabetes and 50.3% of youth with type 2 diabetes report significant disordered eating behaviors. Next, I'm going to talk about epilepsy. So, epilepsy in youth is related to educational underachievement, social stigma, anxiety, and depression. When youth with epilepsy have psychiatric comorbidities, it is associated with poorer psychosocial and medical outcomes and decreased health-related quality of life. A 2020 meta-analysis of anxiety and depression in youth with epilepsy found that the overall pooled prevalence of anxiety disorders was 18.9%, with the pooled prevalence of generalized anxiety disorder being 9.1%, separation anxiety disorder being 4.2%, and specific phobia being 8.4%. Longer epilepsy duration was associated with lower rates of anxiety disorders, and the overall pooled prevalence of depressive disorders was 13.5%, and youth with epilepsy reported significantly higher anxiety and depressive symptoms compared to healthy controls. So we've gone over some general comorbidities, some specific comorbidities. Now let's answer the question why mental health concerns are comorbid with pediatric chronic medical conditions. So chronic medical conditions often present in childhood or adolescence and are associated with psychosocial consequences across the lifespan. These may include sleep disturbances, distorted body image and or eating, discrimination, social difficulties, missed school days, as well as academic impairment. When demands of the chronic illness interfere with educational and social activities, this may, in turn, reduce mental health. Adolescence is also a developmental period marked by biopsychosocial and identity changes. So, managing a chronic medical condition during adolescent development period presents unique challenges for teenagers, families, and clinicians. Youth with chronic medical conditions often feel different than their peers, and they may be excluded from peer groups. Teenagers with chronic medical conditions are often reliant on family to assist with medical care at the time where autonomy should be increasing and dependence on family members should be decreasing. Adolescents who to fit in socially with peers may fail to engage in medical treatment behaviors in social environments to avoid standing out in front of their peers, obviously resulting in negative consequences for their medical condition. Additionally, teenagers may prioritize friends and schools or extracurricular activities over their medical treatment regimens, which can result in suboptimal management of chronic medical conditions. Further, approximately 1/4 of youth with chronic physical conditions report activity limitations, which have been associated with decreased emotional well being and greater odds of mental health conditions. A 2019 study found that youth with chronic illness reported activity limitations had a 3.6-fold increased risk of incident mental health conditions compared to those who did not report activity limitations. I also think it's important when we're talking about chronic illness and mental health to talk about the bidirectionality of mental health concerns. So we know that chronic illness and stress have a bidirectional relationship with uh, each other, such that chronic illness in childhood and adolescence are both causes of significant stress and are affected by stress in other life domains. So, having a chronic illness can cause stress that can contribute to emotional and behavioral problems. And then the emotional and behavioral problems can exacerbate the chronic illness. So, examples of stressors related to illness include missing school days or falling behind in schoolwork, not being able to do activities they used to do or activities other people can do, having to go to the hospital or clinic visits, treatments, uncertainty about a diagnosis, and concerns for the future. I already discussed in this episode that obesity is associated with a higher risk of depression related to things like poor body image, low quality of life, low self esteem, social isolation, and discrimination. However, a depressed mood is also associated with greater risk of obesity as well as a higher body mass index. Symptoms of depression and anxiety are linked with poor control of asthma in children and adolescents. Depression and anxiety have also been associated with poor diabetes management and glycemic control. Youth with chronic medical conditions who have comorbid psychiatric disorders have more difficulty managing their health, which often results in higher rates of non adherence to medical treatment regimens and poorer health outcomes. So, as you can see, the association goes both ways. Depression, anxiety, stress can contribute to exacerbate a chronic illness, and a chronic illness can also cause a child or adolescent to experience depression, anxiety, or other mental health concern. So, how can a therapist or psychologist help? We have a number of children with chronic illnesses. They are living longer. They are having to learn how to cope. And we know that there are comorbid mental health concerns. So, before a child is referred to a therapist or psychologist to help with mental health concerns related to their chronic illness, it's important that physicians and other medical professionals treating the child are not only aware of common comorbidities, but also screen patients with chronic illness for mental health concerns. Then, if the medical professional is concerned the patient is exhibiting comorbid mental health concerns or even subclinical levels of mental health concerns, they can refer out to a mental health professional, such as a pediatric psychologist or other mental health professional who has knowledge and training in working with children with chronic illness and who can work with the patient and family on these specific concerns. So, before I dive into what therapy may look like for children with chronic illness, I want to talk about the various things a mental health professional can do to help a child with a chronic illness. I will be transparent and say what I'm about to say is from the lens of a pediatric psychologist because that's what I do. However, other mental health professionals can also do these things if they are trained to do so. So the first thing is consultation. So this would most likely occur if the mental health professional is embedded in a medical setting. So in the hospital, for example, a pediatric psychologist or other mental health professional can be used as a consultant for children presenting with chronic illness, particularly if there are concerns that they may be comorbid mental health conditions or psychosocial factors impacting disease management or symptoms. This, other than eating disorders, is primarily what I do in the hospital. So a patient comes in, they get a new diagnosis of chronic illness, they already have a diagnosis of a chronic illness. The physicians are concerned about anxiety, depression, stress, social factors, coping. And so they will place a consult for me to come and evaluate the patient. So consultation consists of an assessment of current symptoms, can help seek diagnostic clarification as well as then provide intervention. This could also happen, it doesn't have to always happen in a hospital setting, but a clinic of some sort. So when I was in graduate school, I worked in a pediatric primary care clinic and I would get pulled into rooms for consultation all the time. Consultation can be a one off thing. So, like you assess and give recommendations, or it can be a longer term relationship where you consult, you assess, and then you do interventions either within the medical setting or beyond. Next, we have assessment. So, I just mentioned the term assessment when talking about consultation, and an assessment can take place during a consult, or a patient can be referred out for an assessment. So, this would be the first meeting with a mental health professional to help determine what is going on with the individual. So, a comprehensive clinical intake is essential for conceptualizing the presenting problem, formulating a diagnosis, creating a tailored treatment plan, and setting realistic and achievable treatment goals. The psychologist or other mental health professional will conduct a thorough evaluation to assess biopsychosocial factors affecting disease management, assess for any barriers to care and medical adherence, as well as problematic health behaviors. In addition to assessing functioning related to the chronic illness and its care, it is also important that the mental health professional assess for more general functioning, so that be mood, behavior, eating, sleep, family relationships, peer relationships, school, etc. And during this assessment, the mental health provider will also assess for common mental health comorbidities such as depression and anxiety. Then we come to the last role that a mental health professional can play with regard to working with children with chronic illness, which is intervention. And I'm going to be talking a lot about therapeutic interventions next, but generally speaking, this would be where the mental health professional works with the child and family on coping with their chronic illness, as well as addressing any comorbid mental health concerns. So I will get to specific interventions shortly. However, given the variability across chronic medical conditions and their presentations, there is not one evidence based protocol that should be utilized in treatment. However, there are several core treatment components that are integral in the treatment of youth with chronic medical conditions. So, psychoeducation on the chronic medical condition and any comorbid psychiatric conditions should happen early in treatment and include addressing any gaps in understanding, as a lack of knowledge about chronic medical conditions may impair coping and be a barrier to treatment adherence. We see this a lot in the hospital where, even though physicians have explained the chronic illness multiple times, there are still gaps in knowledge. And that is totally understandable because when you get diagnosed with a chronic illness, you are very stressed and overwhelmed and probably not intaking all the information. So it's important, even though the mental health professional is not the one managing the chronic illness from a medical standpoint, that the mental health professional assesses their understanding of their chronic illness and can correct any misinformation or address any questions they may have, which is why it's important for individuals in the mental health field working with those with chronic illness to have a base knowledge of the chronic illness that they are working with. As you likely know, regular exercise and movement is recommended for all youth. However, for youth with chronic medical conditions, especially those that are painful, this can be a challenge as they become more fearful of overexertion and subsequent pain, resulting in them being underactive, which can lead to physical deconditioning, increased pain, and reduced functioning overall. So there's an intervention called activity pacing, and it's a strategy for learning to modify the activity. So the example of this might be slower pace or rate, more frequent breaks, according to their needs. So this teaches youth to listen to their bodies to reduce the chance of overexertion while also pushing themselves when warranted. So by scheduling activities, it also provides structure to movement to help prevent underactivity. We also know sleep is related to a host of negative outcomes, such as reduced immune functioning, poor concentration, and increased anxiety, depression, and behavioral symptoms. Youth with chronic illness benefit from psychoeducation on sleep and monitoring their sleep habits, such as consistent sleep wake schedule, reducing screen use and bright lights at bedtime, avoidance of naps and late caffeine use, and regular bedtime routines. If an adolescent does exhibit insomnia related to their chronic condition, they may benefit from cognitive behavioral therapy for insomnia or CBTI, or more targeted sleep interventions such as the use of sleep diaries to track sleep, stimulus control intervention, which basically means like you only use your bed for sleep, sleep restriction therapy, so providing a time limit spent in bed to improve sleep drive and reduce prolonged nighttime awakenings, and cognitive therapy, so challenging maladaptive beliefs about sleep, as well as relaxation training. Another core component of treatment is coping. So I always say coping skills are anything that helps reduce the impact of a stressor. A more formal definition is a collection of purposeful, voluntary efforts that are directed at the regulation of aspects of the self and environment under stress. Teaching coping skills to youth with chronic illness can be beneficial for managing both typical life stressors and illness related stressors. Although there are a number of coping skills that can benefit youth with chronic illness, learning problem solving strategies, learning to identify, challenge, and restructure disordered or harmful thoughts, and relaxation strategies have all shown to be beneficial. Lastly, for a therapeutic intervention for children and teens with chronic illness, incorporating caregivers and family in treatment is essential. Many families struggle to identify parent and child roles when managing the chronic illness, and teens may become too reliant on family members for managing health, or the opposite actually may occur, wherein teens become overwhelmed by the responsibility of too much independence with managing their health. Families benefit from psychoeducation on appropriate child and teen roles, reestablishing roles, and learning family problem solving strategies as well as communication strategies. So, although many of these things are core components of therapeutic interventions, things like good sleep, providing psychoeducation, and encouraging activity pacing can be done with physicians as well. So, if any physicians are listening, especially if the individual is waiting to get into the mental health professional to address the comorbid mental health concerns. So I wanted to start with that core components. A lot of it seems probably back to basics. Like, yeah, of course you need good sleep. Of course you need to move your body. Of course you need family involvement. But sometimes we forget those basic things and how much of a positive impact they can make. So now on to more specific therapeutic interventions. First, we're going to talk about cognitive behavioral therapy. I will say, as someone who is heavily CBT trained, and I still use CBT quite frequently, and although I know it is evidence based for chronic illness, I personally tend to take an ACT approach rather than a CBT approach because I have found that often many of the thoughts children have about their chronic illness are not irrational. They're not necessarily helpful, but they are based in reality. And so I find CBT for many can be invalidating or unhelpful. However, with that said, there is plenty of evidence that CBT is effective for a variety of different pediatric chronic illnesses. So, in brief, if you're unfamiliar with CBT, which stands for cognitive behavioral therapy, the basis is that our thoughts, feelings, and behaviors are all connected. And if we challenge or change our maladaptive thoughts, it will in turn change our feelings and behaviors. That is an extremely brief overview, and there's much more to it, but that's all you need to know for this episode. So, there is evidence that cognitive behavioral therapy is a beneficial intervention for the treatment of depression and anxiety in youth with chronic illnesses such as IBD, diabetes, cystic fibrosis, epilepsy, and asthma, as well as for adherence and management of the chronic illness. CBT strategies such as mood monitoring, which is when you record your mood at regular intervals to identify patterns and understand how your environment, stress, and activities affect you. Problem solving and behavioral activation, which I love. And it's basically engaging in positive and enjoyable activities to enhance mood, have shown to be effective in youth with chronic illness. CBT can also teach individuals techniques that promote identifying, challenging, and modifying maladaptive or negative thoughts and behaviors that interfere with adjustment to and management of the medical condition. Some modifications to the CBT protocol are made for youth with chronic illness, including psychoeducation about the relationship between specific illnesses and mood, identifying illness related goals, discussing barriers to behavioral activation based on disease, and identifying illness specific stressors. Other adaptations include changing location to take into consideration the number of medical appointments the child already has. So, an example would be like integrated care, or potentially, if you can and safe, going out to the home so the family doesn't need to travel. Pairing therapy appointments with other appointments. I do this quite frequently in the outpatient setting. If I see that one of my patients has a upcoming medical appointment, I will try to schedule those appointments back to back so they only have to make one trip, as well as offering convenient time slots or offering virtual appointments. For obesity specifically, CBT showed beneficial outcomes when combined with dietary or exercise interventions. So now that I've talked about CBT, let's talk about some other evidence-based interventions for youth with chronic illness, as well as their comorbid mental health concerns. So the first we're going to talk about is family-based therapy. So family-focused interventions focus on realistic and achievable goals for chronic illness management and care. They address positive communication between family members and alter patterns of interaction between family members to support adjustment to and management of the child's chronic medical condition. Interdisciplinary family-based intervention for obese youth has shown to lead to a reduction in depression and improvement in quality of life. And psychological and family-based behavioral interventions targeted at improving regimen adherence and glycemic control have been shown to be effective in pediatric diabetes. Next is coping skills training. I'm going to be talking a lot more about coping skills here shortly. However, coping skills training has been shown to improve quality of life outcomes in youth with type 1 diabetes, cancer, as well as chronic pain. Motivational interviewing. So, as I started the beginning of this episode, I said I recently, back in December of 2024, did a grand rounds presentation on pediatric chronic illness and mental health. In May, I'm going to be doing a presentation on motivational interviewing, and I'll probably end up doing a full podcast episode on motivational interviewing as well. But I'm not going to jump into all of that here. Just know that motivational interviewing is a person-centered therapeutic intervention that involves partnering with patients, so meeting the patients and families where they are at, assessing readiness and motivation to change, validating ambivalence, and identifying patients' goals and values while eliciting change talk. It is a communication approach demonstrated to increase treatment engagement and improve outcomes, as well as enhance an individual's motivation for and movement towards a specific goal by eliciting and exploring reasons for change. Next, we're going to talk about problem-solving therapy. So problem-solving therapy teaches a structured approach to responding to real-life problems. Skills are typically taught in a sequence, including identifying the problem, brainstorming solutions, decision-making, solution implementation, and evaluation revision. Modeling, behavioral rehearsal, in vivo practice, and performance feedback are used to support acquisition and generalization of skills. Problem-solving training delivered in a small group in youth has reduced diabetes-related stress, as well as increased glucose monitoring and improved glycemic control. And last, we're going to be talking about goal setting. So goal setting should be a focus on reducing stigma related to referral for mental health treatment, assessing treatment readiness and motivation, obtaining teen and family buy-in for health and behavioral intervention, and collaboratively setting goals for treatment. Goals for treatment may include helping children and adolescents learn to cope and manage disease-related stressors, improving adherence to medical treatment, teaching strategies to manage chronic pain, improving health behaviors, treating comorbid psychiatric conditions, improving assertiveness and communication skills, and increasing adolescent independence with medical care to facilitate the transition into managing health in young adulthood. With any therapeutic intervention, the goal should not be to manage their medical condition perfectly, but rather reduce barriers to managing their illness, cope with their illness, and improve functioning. So, now that I have discussed specific therapeutic interventions and considerations, I do want to touch more broadly on coping with chronic illness. So, when coping with a chronic illness, like I said earlier, it is really anything that the child or adolescent does to purposely manage or adapt to the stress related to their illness. So we can divide coping types into three categories. One could argue there are very different types of ways to conceptualize coping, but I'm going to do primary, secondary, and disengagement coping. So, primary coping are efforts to directly change the source of the stress or one's response to stressors. So, this can include problem solving and seeking social support, as examples. Secondary coping is an effort to adapt to the stress through reappraisal, positive thinking, acceptance, or distraction. And then we have disengagement coping, which is behavioral cognitive avoidance of the sources of stress. And this can include disengagement, self isolation, and catastrophizing. So, catastrophizing is basically thinking of the worst case scenario. So, when looking at research on coping with chronic illness, individuals with type 1 diabetes who utilize primary and secondary coping strategies, so remember those are ones to directly change the source of the stress or effort to adapt the stress, had better social and behavioral adjustments in adolescence, as well as better social competence, better quality of life, lower HbA1c levels, less depression, and greater positive well being. In contrast, disengagement coping was related to lower self reported social competence and higher HbA1c values. Among youth with chronic pain, secondary coping strategies are associated with lower levels of somatic complaints and less symptoms of anxiety and depression, whereas disengagement coping is related to poorer adjustment, higher levels of somatic complaints, and increases in depressive and anxious symptoms. So even if you're listening and you're not a child and you don't have a chronic illness, I do think it's important to know the differences between primary, secondary, and disengagement coping. As you can see from the results I just shared, disengagement coping has poor outcomes. So if you find when you reflect that you mostly engage in disengagement coping, maybe put some effort into intentionally trying to utilize primary or secondary coping. A few more therapeutic considerations when working with children and families with comorbid chronic illness and mental health conditions. It is important to take a culturally responsive approach when engaging in therapy, as communities of color are disproportionately affected by chronic medical conditions, and youth from communities of color are less likely to present for treatment and have higher dropout rates from treatment compared to their white peers. When working with youth or with teens with a chronic illness, it's important to listen to and acknowledge the patient and family's views and beliefs regarding the medical condition, as well as ask about their family healing practices. So, I wanted to end this episode by talking about the impact of pediatric chronic illness on parents and siblings. As we know, a child with a chronic illness exists within the context of their family, and the illness can and does impact other family members. So, first, talking about parents. Studies have shown that parents of children with chronic illness and disease report significantly greater general stress than parents of children without chronic disease. High levels of parenting stress have been related to adverse outcomes such as depression and anxiety in the parents and their children. Impaired cognitive development and maladaptive parenting practices. Additionally, parental stress may interfere with the management of the child's chronic illness. Elevated levels of parenting stress among parents of children with chronic illness may be related to an additional caretaker tasks related to illness management, uncertainty and lack of predictability with the child's condition, concerns about prognosis, financial burdens that come with having a child with a chronic illness, conflicts between caregiver tasks and other commitments, heredity conditions resulting in feelings of parental guilt, and elevated levels of internalizing or externalizing behavior problems that are often observed with children with chronic physical conditions. Siblings of children with chronic health disorders are at increased risk of mental health problems, and studies have shown that sibling psychological experiences can be characterized by feelings of loss, grief, anxiety, loneliness, jealousy, anger, and guilt. The risk for internalizing problems, so those would be things like anxiety and depression, is somewhat higher than the risk for externalizing problems, so like conduct problems. And this increased risk persists across childhood into adulthood. There are a number of potential reasons why siblings of children with chronic illness are at increased risk for their own mental health concerns, including witnessing acute medical situations, being assigned caregiving roles, being given extra chores and responsibilities, and experiencing differential treatment. There's also some evidence to show that sibling mental health is impacted by parental distress, as well as parental mental health concerns. But there is some good news. There's some buffering factors. So Fredrickson and colleagues in 2023 found that sibling adjustment and parent-child relationships were significant predictors of sibling mental health, such that better adjustment to the sibling's chronic disease and better parent-child relationships were protective factors for mental health. Emotional support from parents specifically was shown to be a protective factor, and further, mother, but not father's mental health predicted sibling mental health. So if mom's doing better, sibling will do better. Mom's doing worse, sibling will probably do worse. Interventions targeting the relationship between siblings and parents focused on family communication and emotional support may be beneficial in improving the mental health of siblings of children with chronic illness. Individual psychotherapy for parents, particularly mothers, focused on stress management and overall mental health may also be beneficial for both parents and siblings. So I think that's where I'm going to end this episode today. I know there is so much more I could cover, but I hope this gave you a good general overview of how pediatric chronic illness looks, what it is, what are some causes, what are some common chronic illnesses seen in children, as well as the relation between pediatric chronic illness and mental health, and how mental health providers can help with the management of the chronic illness and comorbid mental health concerns. Thank you as always for joining for today's episode. Please rate, review, and subscribe to the podcast. Share this episode with someone who you think may find it interesting, and I will see you in the next episode. Bye.
Thank you for listening to today's episode of Psych Talk. I hope you found so much value. If you loved what you heard or gained some knowledge, I would love for you to take a screenshot, put it on your Instagram stories, and tag me at Jessica Lee, PhD. Additionally, I would be honored if you leave a review and 5-star rating so I can continue to help this podcast grow. If you are not already, follow me on Instagram and join my Facebook community, Grow Through What You Go Through. Thank you for joining me today, and I cannot wait for you to join me during the next episode. Remember, you are loved, you are worthy, and you are braver than you know.